Okay, let's dive into this hyperdense execution protocol. We're talking about mastering life-saving differentiation in maternal-fetal emergencies. When you're standing at the bedside of a crashing pregnant patient, you literally don't have time to second-guess the fundamentals, right? This explainer is engineered to strip away all that noise and hyperfocus you purely on the critical variances that dictate immediate life-saving action.
So, our agenda for this briefing is straightforward. First, hypertensive pregnancy pathways. Second, third trimester hemorrhage. Third, alloimmunization physics. And we'll wrap the whole thing up with a mandatory validation drill. Let's get right into it. Section 1, hypertensive pregnancy pathways. Specifically, we're looking at systemic endothelial lysis. We absolutely must anchor our understanding in the first principle concept of preeclampsia. At its core, we're talking about poor trophoblastic invasion leading to a total failure in placental spiral artery remodeling. This triggers placental hypoperfusion, which essentially churns out vasoactive hormones into the maternal bloodstream. The result? Generalized systemic endothelial dysfunction, hypercoagulability, and massive vasospasm. When you're evaluating these patients, you've got to apply serious signal-to-noise filtering. You need to completely ignore that step 2 noise. Things like pre-existing trace proteinuria at 12 weeks, or just a patient's baseline anxiety. Ignore it. You have to hyper-focus entirely on end organ indicators.
We have to ruthlessly separate these presentations by pinpointing critical thresholds. Think about the onset timing. Preeclampsia with severe features is fundamentally defined by new onset symptoms occurring after 20 weeks gestation. Chronic hypertension, on the flip side, is documented prior to 20 weeks. But the real discriminator? That's end organ damage. We are hunting for hard, undeniable evidence, like a blood pressure persistently over 160/110 or platelets crashing well under 100,000.
You have to isolate the exact laboratory variables that dictate an immediate switch from expectant management straight to delivery. You're looking for AST and ALT liver transaminases elevated more than twice the upper limit of normal. You're looking for a serum creatinine greater than 1.1 or a doubling of creatinine if there's no other known renal disease. And crucially, a platelet count dropping below 100,000. If you hit these severe features, especially when you're close to term, there is no debate. The only cure is delivery.
Moving on to Section 2, third trimester hemorrhage. We're focusing on placental shearing kinetics. Okay, the crucial point here is understanding the root mechanical difference between the tearing away of the placenta and a placenta that's abnormally covering the cervical os. In a placental abruption, you've got a premature separation of a normally implanted placenta. It's a mechanical avulsion often triggered by severe preeclampsia, blunt trauma, or cocaine use. Conversely, placenta previa is an abnormal implantation where the placenta is literally physically covering or is dangerously close to the internal cervical opening.
The clinical divide between these two is absolute. Placental abruption brings severe, constant, dark vaginal bleeding, accompanied by a painfully hypertonic, rigid uterus and rapid fetal distress. Placenta previa, that presents with sudden, profuse, but entirely painless bright red bleeding. But listen, here's the absolute most vital takeaway. In a suspected previa, a digital vaginal exam is strictly contraindicated. Why? Because you can provoke a catastrophic, life-threatening hemorrhage just by checking the cervix.
Now let's map maternal and fetal hemodynamics directly to our intervention urgency. If the mother is completely stable with the resolved previa and reassuring fetal status, we manage expectantly with bed rest. Simple enough. But if we shift into emergent hemodynamics, say an active abruption with maternal hypotension, we immediately initiate IV fluid resuscitation, type and cross, and prep for delivery right away. If it reaches critical status, we're talking a rigid uterus, maternal shock, and fetal bradycardia dropping below 90 beats per minute. At that point, you bypass everything else for an immediate emergent cesarean delivery.
Always look for this singular variance in a third trimester bleed. The rigid, hypertonic uterus of an abruption immediately differentiates it from the painless presentation of a previa. If your patient is clutching her abdomen in severe, unremitting pain, your clinical pathway shifts entirely away from previa and directly toward acute retroplacental shearing. Let's transition to Section 3, alloimmunization physics, where we'll explore maternal humoral memory.
The foundational physics here rely on a very specific invisible threat, an Rh-negative mother mounting a humoral memory response against foreign Rh-positive fetal red blood cells. Now, this exposure usually happens at delivery,
But honestly, any fetal-maternal hemorrhage, like a placental abruption, an ectopic pregnancy, or blunt trauma, can introduce those foreign antigens into the maternal circulation, which instantly triggers her immune system.
Let's trace the exact sequence here. It starts with the initial transplacental hemorrhage, leading to maternal B-cell activation. Initially, the mother produces a primary IgM response. But with time, and this is absolutely critical in a subsequent pregnancy, her immune system undergoes class switching to produce IgG antibodies. Because IgG can easily cross the placenta, it travels directly into the fetal circulation, binds to those fetal Rh-positive red blood cells, and triggers massive hemolysis. This leads to profound fetal anemia, a devastating condition known as erythroblastosis fetalis, and potentially hydrops fetalis.
The ultimate red flag variance to watch for is a sinusoidal fetal heart rate trace. If you see this incredibly smooth, undulating, wave-like pattern on the monitor, it's a grave indicator of profound fetal anemia and active hemolysis. It literally means the maternal immune attack is destroying the fetal red blood cells way faster than the fetus can ever replace them.
All right, Section 4. It's time for our mandatory validation drill to test your rapid clinical decision-making.
I want you to evaluate these two side-by-side vignettes. In Vignette 1, we have a 31-year-old at 34 weeks presenting with a throbbing headache, blurry vision, a blood pressure of 168/112, and crashing platelets right at 82,000. In Vignette 2, a 26-year-old at 32 weeks presents with sudden onset, profuse, painless vaginal bleeding, absolutely no abdominal pain, and completely stable hemodynamics. So how do you immediately triage and sequence your actions for these two very different emergencies?
By reordering these findings into a real-world timeline, you absolutely must first recognize that Vignette 2 is a classic placenta previa. You must immediately secure hemodynamics and completely avoid the fatal mistake of performing a digital cervical exam. Do not do it. For Vignette 1, you're looking straight at severe preeclampsia. You have to initiate seizure prophylaxis with a continuous magnesium sulfate drip and administer labetalol or hydralazine to get that severe blood pressure under control before you even prepare for delivery. You stabilize the mother to save the fetus.
I'm going to leave you with this final provocative clinical challenge regarding immunological memory. In a stable Rh-negative mother experiencing a verified placental abruption, exactly how does your immediate intervention intercept the cascade we just talked about? And what happens if you're too late? Think about it for a second. The immediate administration of RhoGAM provides preformed antibodies that literally bind to the Rh-positive fetal cells circulating in the maternal bloodstream. It essentially masks them, preventing the mother's immune system from ever seeing the antigen and developing its own permanent IgG antibodies. But if you fail to give it properly after a sensitizing event, that humoral memory is locked in forever, putting literally every single future pregnancy at risk of fetal exsanguination. Understanding the underlying mechanism fundamentally changes how you view the urgency of the intervention. Keep these execution protocols sharp, and I'll catch you in the next briefing.